What if the pill you take to stop a leaky bladder is like the exact reason your dentist just told you your teeth are rotting out?
Yeah, it's a pretty jarring thought, honestly.
It really is. I mean, we are constantly conditioned to view our physical symptoms in total isolation. We just treat the body like a series of, well, disconnected compartments.
Right, like if you have a dry mouth, you just go buy a special mouthwash.
Exactly. Or you experience pain during intimacy and you quietly look for some localized cream.
And treating those symptoms in isolation is, well, it's where the medical system frequently fails patients.
Mm-hmm.
Because when you start evaluating concurrent dry mouth and vaginal dryness, you're no longer looking at minor, unconnected annoyances.
No, not.
We're actually looking at a systemic moisture shutdown. And that is, frankly, one of the most powerful diagnostic shortcuts available to us.
Which brings us right to it. Welcome to a deep dive into that very shortcut. Today, we are exploring the surprising, really intricate web of evaluating concurrent, dry mouth, and vaginal dryness.
And we've got a lot of ground to cover.
We really do. We are pulling from a pretty heavy stack of sources for this one, including medical guidelines from the NHS, the American College of Rheumatology, the Mayo Clinic, and the Scottish Government's polypharmacy guidance.
Some really comprehensive stuff in there.
Yeah. And the mission today is to give you, the listener, the tools to understand the root causes of systemic dryness.
Whether that origin is chemical, hormonal, or, autoimmune.
Right, so you can effectively advocate for your own health.
Because the body's mucosal membranes, so the tissues lining your mouth, your eyes, your digestive and reproductive tracts, they are all connected by the same underlying physiological rules.
They're a network.
Exactly. When multiple mucosal surfaces dry up simultaneously, your internal systems are actively flashing a warning light.
Okay, let's unpack this, because before we jump into complex immune responses or, hormonal shifts, I want to look at something completely preventable first.
The pharmacological factor.
Yes, the medicine cabinet. I want to talk about acetylcholine. It's just a massive heavy hitter in your nervous system.
Yeah, it really is.
Think of acetylcholine as the body's internal sprinkler system. It's the primary neurotransmitter of the parasympathetic nervous system, the rest and digest network, basically.
Right.
And it's responsible for pushing out saliva, stimulating tears, maintaining cognitive alertness, and even controlling involuntary muscle contractions.
Yeah, and the way it works is acetylcholine binds to what we call muscarinic receptors all throughout the body.
Okay.
So when it binds to those receptors in your salivary glands, well, the glands secrete saliva. When it binds in the gut, it promotes peristalsis, moving food along.
Just keeping the pipes working.
Basically, yeah. It essentially tells your body to perform all the essential background maintenance tasks that keep your tissues hydrated and functional.
But, and this is a big but, the sources highlight a massive issue with our everyday medicine cabinets. So many common drugs act as anticholinergics.
And that means they actively block acetylcholine from reaching those receptors.
Right. Using the analogy, these drugs basically walk down to the basement and completely turn off the main water valve to your internal sprinkler system.
What's fascinating here is how the medical community quantifies this. They use something called the anticholinergic burden, or ACB scale.
The ACB scale.
Yeah. Healthcare providers use this scale from 0 to 3 to measure a drug's anticholinergic potency.
Okay, so 0 is?
A 0 means no activity at all, while a 3 indicates a highly potent anticholinergic effect. And the real danger lies in that word burden,
Yeah, because it's cumulative.
Exactly. It adds up over time and across different medications.
Which is why the Scottish Government's polypharmacy guidance is incredibly strict about this accumulation. Like, they point out that a patient might be taking, say, oxybutynin for an overactive bladder.
And that carries a score of 3.
Right, but then they are also taking amitriptyline for nerve pain or depression.
Which is another 3.
Yeah, and then maybe they grab an over-the-counter antihistamine or sleep aid, like Piriton or Nitol.
Which also carry heavy anticholinergic properties.
Suddenly, that patient's ACB score is just sky high. The muscarinic receptors are completely blocked systemically.
And the fallout from that isn't just a slightly parched throat. I mean, the cumulative side effects include profound dry mouth, severe constipation, blurred vision.
Urinary retention.
Right. and really catastrophic impacts on the central nervous system.
Yeah, the cognitive decline aspect genuinely shocked me. The Scottish guidelines emphasize that a high anticholinergic burden is a major risk factor for cognitive impairment,
And an increased risk of dementia in older adults.
which is terrifying. We're talking about a patient feeling incredibly confused or forgetful and probably just attributing it to getting older.
When it might actually just be their bladder medication and their sleep aids stacking up.
Wow.
And that phenomenon fuels what we call a prescribing cascade. It is one of the most dangerous traps in polypharmacy.
How does that usually play out?
Well, a patient takes a medication, let's say, an older antidepressant. A few weeks later, they visit their doctor, complaining of severe dry mouth and new, really uncomfortable vaginal dryness.
But the doctor doesn't connect the dots.
Exactly. The doctor doesn't recognize these as systemic anticholinergic side effects of that first drug. Instead, they diagnose a new pathology entirely.
Oh, no.
Yeah, and they prescribe a second medication to treat the side effects of the first.
So the patient leaves the clinic taking a new pill for their original pill's side effects.
Compounding the chemical burden on their body, yeah.
That is wild.
That happens every single day, honestly. This is why evaluating the anticholinergic burden is the mandatory first step when someone presents with systemic dryness.
You have to rule out the drugs first.
We have to strip away the chemical interference before we can see what the body is actually doing.
Okay, so let's follow that logic. The physician does the medication review, right? And the patient's ACB score is practically 0. No offending medications are found.
But the female patient is still sitting in the office experiencing profound dry mouth alongside severe vaginal dryness.
Right. So this pulls us away from the medicine cabinet and into our second major root cause, which is the hormonal shift.
We move from a chemical blockade to a physiological depletion.
According to the Mayo Clinic and the NHS, we are looking at genitourinary syndrome of menopause, or GSM.
Yes.
And I have to say, reading through the history of this diagnosis is fascinating. Like, up until 2014, the medical establishment called this vulvovaginal atrophy.
Yeah.
I can't imagine a more demoralizing and clinical way to describe a completely natural life transition.
The terminology update to GSM was a crucial victory for patient advocacy, really. Vulvovaginal atrophy isn't just terrible branding, it is medically inadequate.
How so?
Well, it hyperfocuses on one specific anatomical location, and it completely ignores the broader regional impact.
Yeah, okay.
GSM is a much more comprehensive term that finally acknowledges how the lower urinary tract and the genital tract are deeply interconnected. They share the exact same embryological origin.
Which means they share the same vulnerabilities, I assume.
Exactly. GSM is triggered by a dramatic drop in estrogen, whether that's through natural menopause or the surgical removal of the ovaries, or even estrogen-blocking breast cancer treatments.
Because estrogen is doing a lot of structural work down there, right? The sources note that estrogen receptors are absolutely abundant in the vagina, the urethra, and the bladder trigone.
The bladder trigone being that smooth triangular area at the base of the bladder.
Right.
And estrogen basically dictates the structural integrity of those tissues. It signals the cells to produce glycogen.
Which feeds the healthy bacteria.
Yes, the lactobacilli. And that maintains an acidic pH that kills off harmful pathogens. Plus, estrogen promotes blood flow, it keeps the mucosal lining thick and elastic, and maintains natural lubrication.
So when the estrogen production plummets, the architectural support of those tissues just collapses.
It does.
And the symptoms are brutal. The mucosal lining literally thins out and becomes incredibly fragile. Women experience severe vaginal dryness, intense pain during sex, which is known clinically as dyspareunia, and a physical loss of the vaginal rugae. Those are the natural folds that allow the tissue to stretch. There's also introital retraction, where the vaginal opening actually physically narrows.
It's incredibly painful. And furthermore, because that protective acidic environment is destroyed and the urethral tissues thin out, harmful bacteria can easily travel up the urinary tract.
Leading to infections.
Yes. This results in chronic, recurrent urinary tract infections that can just be debilitating. And we should note, unlike hot flashes or night sweats, which often peak and then gradually burn out as the body adjusts, GSM is chronic.
It doesn't just go away.
No, it is relentlessly progressive. Without targeted treatment, the tissues will continue to degrade.
Okay, I need to challenge the premise here, though.
Go for it.
We are talking about evaluating concurrent dry mouth and vaginal dryness. If GSM is strictly caused by a lack of estrogen targeting the pelvic region, the vagina and the bladder, how does that possibly explain a dry mouth?
That's a great question.
I mean, the salivary glands don't rely on estrogen the way the bladder trigone does, right?
No, they don't.
Yeah.
But if we connect this to the bigger picture, it reveals a tragic clinical irony that brings us right back to our first topic.
Oh, the medications?
Yes.
Hmm.
Think about what happens when the bladder tissues thin out from GSM. The bladder loses its protective lining and becomes highly irritable.
Which causes urinary urgency. The patient feels a sudden, uncontrollable need to rush to the bathroom.
Precisely. And that is the symptom that drives most women to seek medical help. They book an appointment for the urinary urgency.
Okay, I see where this is going.
The physician hears urgency and diagnoses an overactive bladder. So to calm those bladder spasms, the doctor prescribes an antispasmodic medication.
Drugs like sulfasalazine or oxybutynin, which we just established are potent anticholinergics with an ACV score of 3.
The cycle is devastating. The patient is already experiencing severe vaginal dryness as a direct physiological result of the GSM.
Right.
She is then inadvertently prescribed a medication to treat her bladder irritability that systemically blocks acetylcholine.
Effectively shutting down her salivary glands and causing extreme dry mouth.
Exactly.
Wow, so the concurrent dryness is actually an overlapping web. It's a hormonal condition colliding with a chemical side effect.
Yes, and that perfectly illustrates why looking at symptoms in isolated silos, treating the bladder without considering the menopause or treating the mouth without checking the medication list is so dangerous.
It demonstrates how a localized hormonal deficit can literally cascade into a systemic pharmacological crisis.
Absolutely.
Okay, we've cleared the medicine cabinet and we've ruled out the hormonal depletion of estrogen. But what if the patient is entirely unmedicated and, say, nowhere near menopause?
Right.
What if the body is actively launching an attack on its own moisture-producing factories?
And we leave pharmacology and endocrinology behind, and we enter the realm of autoimmunity.
Specifically, Sjogren's disease. According to the NHS and the American College of Rheumatology, Sjogren's is a systemic autoimmune disorder that primarily targets women, usually striking between the ages of 45 and 55.
And in the UK, it affects roughly 1 in 2,000 women.
The pathology here is that the immune system basically misidentifies the body's exocrine glands as foreign threats and just attacks them.
And we should clarify, exocrine glands differ from endocrine glands. Endocrine glands secrete hormones directly into the bloodstream.
Like the thyroid.
Right. But exocrine glands secrete substances outward, through a duct, onto an epithelial surface.
Okay.
So the salivary glands in your mouth, the lacrimal glands producing your tears, and the secretory glands of the vaginal mucosa are all exocrine glands.
And in Sjogren's, white blood cells basically infiltrate these glands and destroy their ability to function.
Yes.
The resulting symptoms are severe. The dry mouth isn't just nothing up thirsty, it is profound. Patients report having to constantly sip water just to generate enough moisture to swallow a bite of a dry cracker.
It's awful.
And they describe a constant gritty sand sensation in their eyes. And of course, they experience severe vaginal dryness.
And because the disease is systemic, it rarely stops at the mucous membranes. It frequently causes debilitating joint pain and just crushing fatigue.
We also have to distinguish between primary and secondary Sjogren's, right?
We do. Primary occurs on its own, independent of other conditions. Secondary Sjogren's develops in tandem with another major connective tissue disease.
Like what?
Most commonly rheumatoid arthritis or systemic lupus erythematosus.
Here's where it gets really interesting. When you look at how hyper-specialized our medical system is today, a Sjogren's patient is just caught in a labyrinth.
Oh, absolutely.
They might go to an ophthalmologist for the gritty eyes, and then a dentist because their teeth are suddenly deteriorating, and then a gynecologist for the painful sex.
Right. They are handing a different clue to 3 different specialists who, frankly, rarely communicate with each other.
Exactly. You're showing everyone a different puzzle piece, but no one is looking at the picture on the box.
And this raises an important question. Who serves as the diagnostic architect here? Who takes those isolated clinical clues and builds the systemic picture?
And the sources say that's the rheumatologist.
It is. This is why rheumatologists are so critical. When a patient reports concurrent dry mouth, gritty eyes, and vaginal dryness, a rheumatologist immediately suspects systemic autoimmune involvement.
And initiates the proper diagnostic workup.
Exactly.
The diagnostic criteria outlined by the American College of Rheumatology are very specific, actually. They start with blood tests looking for specific autoantibodies.
Right.
The big ones are ANA, and specifically anti-SSA, which is also called Rho, and anti-SSB, also called LA.
But the sources point out that blood work can sometimes be inconclusive. You can have Sjogren's and not test positive for those.
Right, so they move to objective output tests.
They need to measure the actual functional deficit. For the eyes, they use the Schirmer's tear test.
How does that work?
They hook a tiny calibrated strip of filter paper inside the lower eyelid for 5 minutes to measure the exact tear production in millimeters.
Oh, wow.
Yeah. And for the mouth, they conduct salivary flow tests, measuring the exact volume of saliva a patient can produce over a specific time frame.
Like spitting into a cup for 5 minutes.
Basically, yeah.
But if those still don't provide a definitive answer, they bring in the gold standard, which is the minor labial gland biopsy. They actually take a tiny tissue sample from the inside of the lower lip.
And under a microscope, a pathologist looks for focal lymphocytic sialadenitis.
Which means?
They're literally counting clusters of lymphocytes, white blood cells, that have invaded and surrounded the salivary tissue. Finding those clusters is definitive proof of the autoimmune attack.
And getting that definitive diagnosis isn't just about validating the patient's suffering. It's really a matter of life and death.
It is.
The sources are very clear on a specific severe complication. Patients with a confirmed Sjogren's diagnosis carry a significantly increased risk of developing lymphoma, which is a type of blood cancer.
Yeah, the chronic hyperactive state of the immune system's B cells in Sjogren's creates an environment where those cells can eventually mutate into lymphoma.
That is a sobering reality.
It underscores our entire discussion. The dryness is not merely a lifestyle inconvenience, it is a clinical marker of profound systemic inflammation that demands lifelong, vigilant oncology monitoring.
So what does this all mean for the patient? We have unpacked the chemical burden of anticholinergics, the hormonal architecture of GSM, and the exocrine destruction of Sjogren's. We know the why.
Time to pivot to the what now.
Exactly. How do we systematically treat concurrent dryness based on the specific root cause?
Well, management must absolutely match the underlying mechanism. You cannot treat an autoimmune attack with estrogen, and you cannot treat a chemical blockade with an immunosuppressant.
Makes sense. Let's start with the anticholinergic burden. If the dryness is pharmacologically induced, the clinical protocol is a comprehensive medication review aimed at deprescribing.
Yes. The Scottish Polypharmacy Guidelines suggest switching out the high-burden drugs for therapeutic equivalents that don't block acetylcholine.
Right. For example, if a patient is taking oxybutynin for an overactive bladder, which again has an ACV score of 3, they can often be switched to mirabegron.
And mirabegron targets the beta-3 adrenergic receptors instead of the muscarinic receptors.
So it calms the bladder with 0 recorded anticholinergic activity. The bladder gets treated and the sprinkler system turns back on.
Exactly. But it requires a physician willing to meticulously audit a medication list and understand alternative pharmacological pathways.
Okay, moving to GSM and the hormonal shift. The Mayo Clinic outlines both non-hormonal and hormonal interventions. Non-hormonal options are the first line of defense, but there is a massive amount of confusion out there between a lubricant and a moisturizer.
Oh, hugely.
What is the functional difference, and why do the guidelines strictly prohibit the use of petroleum jelly like Vaseline?
The distinction is vital for tissue health. A lubricant is an on-demand, point-in-time solution. It's used immediately prior to sexual activity just to temporarily reduce friction.
Okay.
A vaginal moisturizer, like Replens, for example, is entirely different. It is a maintenance therapy used regularly, usually 2 to 3 times a week, regardless of sexual activity.
It's the difference between applying a daily face lotion to keep your skin healthy versus putting on a bandage when you get a cut.
That completely captures the clinical intent. The moisturizer is formulated to adhere to the vaginal mucosa, continuously mimicking natural secretions.
Lowering the pH back to an acidic level?
Yes, and maintaining the cellular integrity of the tissue over time. Now, regarding petroleum jelly, it is fundamentally incompatible with the mucosal environment.
Why is that?
Chemically, oil-based products rapidly degrade the latex in condoms, causing them to break. And biologically, petroleum jelly does not absorb into the mucosal tissues.
It just sits there.
It creates an impermeable barrier on the surface that actually traps bacteria, drastically increasing the risk of bacterial vaginosis and yeast infections.
Oh, wow.
Yeah, so for internal use, guidelines mandate water-based or silicone-based products.
But if the moisturizers aren't enough to reverse the GSM symptoms, doctors move to hormonal options. This usually involves low-dose vaginal estrogen applied locally via creams, tablets, or rings.
Right, and that revives the specific tissues without significantly raising estrogen levels in the systemic bloodstream, which is great.
The sources also mention daily DHEA suppositories or an oral selective estrogen receptor modulator called ospemifene.
Which specifically treats the painful intercourse by mimicking estrogen's beneficial effects on the vaginal tissue.
So the objective with all of these interventions is really just to restore the cellular architecture and elasticity that the lack of estrogen destroyed.
Precisely.
Finally, how do we manage Sjogren's disease, where the glands are actively being destroyed by the immune system?
When the exocrine glands are under immune attack, we often have to chemically force them to work. Rheumatologists utilize prescription salivary stimulants known as secretagogues, specifically pilocarpine and cevimeline.
These drugs act as muscarinic agonists, correct? Like the exact physiological opposite of the anticholinergic drugs we discussed earlier.
Spot on. They bind directly to the muscarinic receptors and aggressively stimulate whatever functional glandular tissue remains to secrete saliva and tears. Patients also heavily rely on over-the-counter interventions, like xylitol products, lozenges, and such, to stimulate flow.
Or artificial saliva sprays that coat the oral mucosa using carboxymethylcellulose to provide temporary mechanical relief.
Right.
But we absolutely cannot skip over the dental urgency and Sjogren's management. Every single medical guideline we reviewed hammered this home. Saliva is not just water.
No, it is not.
It is a complex fluid packed with calcium, phosphate, and antibacterial enzymes. It is the primary protector of your dental enamel.
And without a constant flow of saliva, the oral environment becomes highly acidic, and the risk of catastrophic dental decay just skyrockets.
Patients can literally lose multiple teeth in a matter of months.
It's tragic. Dental management in Sjogren's requires a rigid, uncompromising protocol, high fluoride prescription toothpaste, constant use of sugar-free gum to keep the glands active, absolute avoidance of enamel-stripping acidic drinks, and mandatory rigorous dental checkups every 3 to 6 months.
That's intense.
And dentists are often the frontline diagnosticians for systemic dryness. If they see sudden, rampant decay along the gum line in an adult, they should immediately be referring that patient to rheumatology.
Everything is incredibly interconnected. I mean, we have covered a massive amount of physiological ground today.
We really have.
We've seen how the seemingly simple task of evaluating concurrent dry mouth and vaginal dryness is actually a masterclass in systemic medicine.
It demands that we audit the anticholinergic burden of our daily medications.
Understand the profound structural collapse caused by estrogen depletion in GSM.
And recognize the aggressive systemic markers of autoimmune conditions like Sjogren's disease.
It reinforces the reality that you just cannot treat the oral cavity in a vacuum, separated from the pelvic floor.
Or manage the pelvic floor without interrogating the medicine cabinet.
Exactly. Which leaves us with a final thought for you to ponder based on the research we unpacked today. Society constantly encourages us to view symptoms like a persistently dry mouth or localized discomfort during intimacy as trivial inconveniences.
Just another part of getting older that we should quietly tolerate.
Right. But as we've explored today, saliva and natural mucosal moisture are not just convenience factors. They are highly active, vital protective shields for your immune system and your structural health.
Yeah, absolutely.
If a simple lack of saliva can literally cause your teeth to decay and fall out, and if minor vaginal dryness can lead to chronic, systemic bacterial infections, what other minor annoyances in your body are actually glaring alarm bells for a much bigger physiological puzzle?
It is always worth tracing the diagnostic wires back to the source.
Thank you for joining us on this deep dive. Keep questioning those isolated symptoms, keep learning about the incredible mechanisms driving your body, and most importantly, share your newfound knowledge with your own healthcare providers. Until next time.